I would like to welcome everybody to this SDSMA Center for Physician Resources presentation on MIPS, performance categories, and scoring of MIPS. This presentation is brought to you in partnership with Avera Health and the South Dakota Center for Advancement of Health Information Technology, or KHIT. This is our fourth and final program in this series dedicated to MACRA. Please note, we're going to try to keep all phone lines open this evening because we generally try to be fairly laid back and fairly open for interaction, so that way you can ask questions. But if we do pick up some background noise respectful to our speaker, we'll go ahead and mute the phone lines, but we will stop throughout times of the presentation to see if there are questions. With that, I'm going to turn the presentation over to Mr. Dan Frederick of KHIT. Dan is the Executive Director of KHIT, and he is a Certified Information Systems Security Professional. Dan has more than 30 years of experience in information assurance and adult technical instruction. I have to say I have had the privilege of working with Dan for a number of years now, and he is certainly a guy and certainly a wonderful resource. So at this time, Dan, I'm going to ask you to further introduce yourself and lead us through the discussion.
Thank you, Mark, and thank you all for spending an evening with us again, our fourth and final evening in this series. Hopefully you've got some benefit out of the first three. This one's going to be a little bit faster pace. I've got about 45 slides, and typically I try to have somewhere between 25 and 30 for a 50-minute presentation. So what across to you early is that don't worry if it seems like I'm really flying through a couple of the slides. It's sort of intentional. I wanted to make sure that I had all the information in here because I know that Mark and the Medical Association makes these slides available to you. So I wanted to make sure that I got the content in the slides if I didn't get it across clearly. So there's some of these slides that we'll go through really quickly, even though they might look like they have a lot of content on them. As I hope you've noticed from the previous sessions, we'll focus on some very specific areas in this. As we get rolling here, and I'd just like to thank you for taking the time to spend their Thursday evening with us. So we'll be covering mostly scoring things, right? You know, the last three times we've talked kind of in depth about the different categories. We talked about the quality category and the advancing care information and quality improvement activities sections. So tonight we're going to focus a little bit more on how those sections are all scored, and I'm hoping this will tie it all together for you in this final adjustment. And as always, if you have a question, I'll probably stop every 3 or 4 slides just to give you, a few moments to jump in. When I do that, I would encourage you to jump in right away because I'll only pause them for 10 or 15 seconds when I do that. So if you have your questions, feel free to jump right in. And then if we end up having a few questions during that time frame, then that's good. So I don't want you to be a wallflower and wait on asking the questions if you have one. So, we'll be talking, like I said, about how the payment adjustments work out this composite scoring system. Essentially, it's a 100-point scale, and that's what we're going to talk about. We're going to talk about how that breaks down a little bit, and we'll talk just briefly on how the payment adjustments in the years, because we've talked about that kind of in every presentation. So, again, all these slides come from CMS. So I am certain that we are using as accurate of CMS information as we have available to us at this time. So, when we talk about MIPS, one way to think of it is rolling up of certain legacy programs. Many of you are already familiar with PQRS and have probably been doing it for a few years. The value modifier, HR incentive programs, all of those legacy programs, their last performance period is in 2016 or this year that just passed. PQRS, the incentives and penalties lagged performance year by 2 years. So 2018 will be last payments, those PQRS payments that are ending. Coincidentally, 2017, the year we're currently in now, is the first year of MIPS performance, and then those those adjustments will take place in 2019. So as EQRS payments and meaningful use phase out, MIP, QPP, Quality Payment Program is what they're calling it, will be phased in. We've already seen this 3 or 4 times over the last couple months. Reality is that the sustainable growth rate, SGR, just wasn't going to work, and it just kept getting moved down the line to the point where in 15, if they hadn't finally repealed it, you know, everyone was in for a 21% cut on their Part B payment. So that was following the old formula. MACRA replaces that. MACRA is now being called the Quality Payment Program. So when you look at MACRA or the transition to quality, they want you in alternative payment models where you're managing the risk and you are at some risk, right, or at least in a shared risk model. So if you, in the interim, there is going to be a merit-based incentive program. That's what MIPS is. And essentially, in that case, managing penalties and incentives. So, you know, love to have everybody in advanced payment models, and that's where everybody is trying to get to. That's just taken some time to develop. I've seen this a lot of times already as well. MEs, DOs, dentists, chiropractors, optometrists, Ps, NPs, CPs, certified nurse midwives. In a couple 3 years, there's going to be a few more eligible providers, speech therapists, occupational OTs, PTs, and some other of the allied health professionals. So these first couple of years, it's this group, unless you are a further Medicare Part B participant, in which case you are not subject to MIPS or eligible for MIPS, depending on how you look at it. If you fall below a low patient volume, you are also not subject to MIPS. So the low patient volume thresholds are $30,000 and 100 patients. So you're going to be eligible for MIPS if you have 30,000 in Medicare Part B and 100 patients. If you have fewer than 100 patients, if you have 101 patients. If you have exactly 100 patients, you'll meet the cutoff. Or you have less than 30,000. So if you're looking at it as am I eligible, it's an or if you're looking at it going down, it's an and if you're going up. So 30,000 and 101 if to be eligible. So keep in mind, this is a provider payment program, not hospitals and facilities. Certain in advanced APMs are not subject to MIPS. That's what they're trying to get everybody is into advanced APMs. And there are very few advanced APMs at this point. You know, some of them that are two-sided risk, most comprehensive ESRD, kind of CPC Plus is one. I don't think we have anybody in South Dakota that's CPC Plus. Net ACO model is. So if you're in one of those 3 cases, you aren't subject to MIPS. When you think about your participation in MIPS, you're going to have to and make some options and be able to make some options, right? You can file as an individual under your NPI or file as a group. Their definition of group is 2 or more clinicians that have assigned their billing rights to a single tax ID. And the permit itself, by and large, follows the tax ID. And the assumption is if you're an individual operating under a single NPI, you probably have a tax ID in that case. The other form is, as a group, would be as a MIPS APM entity. And the MIPS APMs are kind of special cases because they're not statutorily considered an advanced alternative payment model. So you think about some of the MSSP, the shared savings programs, those are not advanced alternative payment models. like the savings program track 1 are not advanced APMs, but would be MIPS APMs, and they're scored as if you're in an APM. So scoring is a little bit different. That's a special case. It probably should be the 5th in the series, but focusing this on MIPS. So how this is going to be scored over the next few years, those special cases of those MIPS APMs, they will utilize the APM scoring, and you're going to basically have to follow these 3 criteria here. As a provider, you would have to participate as an APM that actually has an agreement with CMS. You'd have to have at least one MIPS-eligible clinician in there on that participation list. And that participation list, as we're going to see, is generated by CMS. And it's going to be generated at very specific times of the year. So to get advanced AP, or those MIPS APMs, payment incentives on performance you are measuring in your advanced or your APM, as opposed to using the MIPS scoring criteria. So it's sort of an interim step between MIPS and advanced APMs. They'll bring out a list on March 31st, June 30th, and August 31st, and those providers that are on that APM participation list would be the provider that would be considered eligible to be in those MIPS APMs. I'm going to a few seconds if there's any questions on that. That's probably a different concept than we've talked about over the last 3 sessions. Okay. We'll MIPS timeline a little bit, like we said earlier, as PQRS phases out, as the EHR incentive program phases out, and this is the Medicare side. The Medicaid side of EHR incentive program still eligible for a couple years. But as that phases out, the MIPS timeline will phase in. So this is the year. I mean, we are in performance year 1. You would be tracking data today for performance year 1. You're going to have some opportunities to track data all year long if you choose to do that, or a 90-day period, or even a test scenario where you just kind of dip your toe in the program. So perform period starts January 1, ends December 31st. You then report on your measures and your outputs by March 31st of 2018. The 2018 will be the feedback year for CMS to provide you feedback. And even if you're not subject to MIPS, there are some people who will be doing, who will be participating, and you're right to do. You can participate, even though you wouldn't get incentivized or penalized. You would participate just to get the feedback, on the assumption that forward, if the program is successful, private payers will likely adopt this model. You know, the movement has begun. So, then in January, your payments will be subject to the adjustment based on your performance year of 2017. That graph time, the first blue balls here, 2017, 2018. Those are the 2 years that initially you're going to end up doing. Those are performance years, but without payment adjustments. Once you get into 2019, those payment adjustments graduate, and the performance years will always lead the payment adjustment years by 2. So when you get into the 2019 performance year, you're going to take that impact in 2021. So start out at plus or minus 4%, and in 2022 and going forward, plus or minus 8%, so an 18% swing. Most of you are operating on much closer margins than that, and I understand that CMS isn't the sole beneficiary, but you know, for you that could be a really significant impact, an 18% swing. So this is one we've seen multiple times already. Not going to spend very much time on it at all. The data areas here and the things to understand if you're a first-time seer of this graph. If you don't report and you don't do anything and you are a MIPS eligible provider, you will be taking a 4% reduction in 2019. So they've set the bar very, very low. That 3-point line that you see between the deficits and the positives is a scoring threshold of 3 points out of 100. So a really low bar, and they're doing that with the test method. So you can reach that to get no adjustment to the schedule in 2019. If you get more than 3, somewhere between 3 and 70 points on that 100-point scale, you are getting closer always to that additional performance threshold. So your numbers will start to go up and you'll be getting a larger percentage incentive. If that 70 line, you automatically get another 0.5% on top of whatever you get for an incentive. Plus, there's a distribution of about $500 million a year for those providers that make it over that additional performance threshold. So, then you've been looking at it. I think there's some real opportunity up front to take advantage of it because my suspicion is, and most of the things we've been hearing, is there are a lot of people that are going to take it very gradually. Not a bad strategy either, but I think you potentially be leaving some good incentives on the table by doing that. We'll look at calculating that final score. I said it's a 100-point scale, but you're in different categories. Clinical quality performance is 60% of the 2017 scoring. Cost performance is actually 0% for 2017. Clinical improvement activities is 15%, and it's in care information, or if some of you are familiar with Meaningful Use Program, that's essentially what advancing care information is. That's worth 25%. You multiply all that by 100 because you end up with less than 100, obviously. We take each one of those percentage basis. So, as we described a couple of slides earlier, if you don't participate, that's one pace that you're going to take, which means that you do not say anything by March 31st of 2018. Happens, you will receive that 4% negative payment adjustment. The ting phase, which there are a lot of people that are going to do that, and that's what I describe as dipping your toe in. If you submit a minimum amount of data, one quality measure, one improvement activity, the basic parts of meaningful use, you will get to that 3-point threshold, and you will get a 0 adjustment. Obviously, we don't want to see you do that. I mean, we want to see you succeed as quickly as possible. We love all the people that we work with and within hearing of me to do a 90-day submission for a partial year and get up into those positive incentives. And even if you don't get a full year done, because the reality is if you start today, you're not going to get a full year done now. But if you can do your full performance year, that's when you maximize your benefits the most. So if you decide you want to do a 90-day period, I would definitely suggest trying early, because if you can tell October 2nd, which is the official deadline, everything has to go perfect in order for you to get 90 days in. If you start early and you have to adjust your time period, you have a lot more leeway. In particular, if you look at the quality measures, there's a threshold of encounters that you have to meet. You have to have a minimum of 20 encounters in most of the quality measures, and in a lot of cases you won't get that in the 90-day period, so you might have to extend your 90-day period out to get those quality measures. So, you know, the idea would be to start early. This shows what we talked about before. Cost is not going to be a factor in 2017. They're taking the value modifier base out, and it's only going to be the 3 categories there. Basically breaks down like this. The quality measures be about 60% of the score, meaningful use or advancing care information about 25%, and then the new category of improvement activities is 15%. Over time, that value modifier is going to come back in. It's probably not going to come in 2018 at 30% like I've got it in this graph, but the statute is it's going to eventually be 25% meaningful use, 15% improvement activities, 30% quality, 30% value. So that's where it's going to get to statutorily out in 2021. So to this point.
Hear me?
I can't.
This is Doug Traub. I'm an internal medicine doc, and I have a question that's probably going to give everybody a headache.
I'll try my best.
So this is fine. We have a stable group of physicians and providers, and everything's going along, and we're trying to meet all the things that we need to do. But in life, we have people that get older, and we have new physicians that come out of training and join us. They will not be available for the first year, according to the statutes, for participating in this. How do we get through that mess of having people coming and going, and then their information actually influences the payments 2 years later?
Right, Dr. Traub, that probably will give some people some headaches. I can't answer that question tonight, and part of the reason I can't answer that question tonight is because CMS has released exactly how the attestation process is going to work. Whether they're going to do that, we have been hearing that there may be some attestation by proxy stuff available to you. We don't know exactly what that's going to look like, so I would be really reluctant. And I understand where you're coming from, and that's going to be about saying, hopefully this will be enough, is that we will be here to help you through as much as we can, and that is part of the role, is taking questions exactly like you just posed up through our channels to CMS and having them try to answer those questions. This is a very legitimate question. I just can't answer it for you tonight. I apologize.
Thanks. Stay tuned.
Okay. And we will work with you on that. I mean, we will definitely, in fact, if you would, I'm going to, my contact information at the end, if you would jot that down in an email to me, then I will make sure that it gets asked up through the CMS channel, and we will get an answer. I can't promise an answer that you'll like, but get an answer.
Maybe any answer is better than no answer. Thank you very much.
You're welcome. So in the quality piece of this, the 60% category is actually in QRS you picked 9 from some very specific areas, and they've backed off that a little bit. It's no longer 9. You have to be able to do 6. Out of, there's about 300 measures, and actually they've got a pretty good website now, QPP, Quality Payment Program.cms.gov, and they have a way that you can explore measures and you can download them. They tell you whether they're high priority measures or not. It's really it's a site from a CMS perspective. You do have to pick, to get to fully participate, you have to pick 6, and at least one of them has to be an outcome measure as opposed to all process measures, or a high priority measure. And they've got some that are designated as high priorities. Patient experience ones are designated high priority measures, even though they might not be outcomes measures. Excuse me. If you're a specialist, you may also select from a specialty set of measures. Again, I think there's still some information coming out about that. I'm not sure that are they're in tune with exactly what all that means from the specialty specific side. We have asked a couple of questions along that line, and where did we get back is it's get kicked up the chain, and then we get answers sometime out. So I believe they're still working on some of exactly how some of those specialty measures might play out. If you be in a larger group of 15 clinicians or more, and you meet some minimum thresholds, there's a readmission measure. You don't have to do anything on that. They will take that from claims. So there's no requirement to submit any information there. There are different requirements if you are using the CMS web interface. So for those of you who in organizations larger than 25 practitioners, you may be submitting via web interface, and there are some different requirements there for those larger groups. Essentially, those 6 measures that you pick have a score of 3 points, and then depending on where you are along the continuum of that measure, you can anywhere between 3 points and 10 points. That is assuming that these measures all have reliable scores, which means that a benchmark exists, you have a sufficient case volume, as in the many cases we referenced a little bit earlier. This is where you might get in trouble in a 90-day window. 20 cases might not be a long enough time to get 20 cases. Readmissions is the only one actually that's got a 200 case count for remissions. Then you have to at least meet 50% of your data commitment. So is no benchmark, and I want to really point this out because there needs to be some caution here. If there is no benchmark, then you're only going to get 3 points. You will never be able to earn the 7 to 10 points, and the reason that is because they say it's not reliable enough to accurately measure you against those benchmarks. So where that's going to come into play is in some of the very specialized measures. Unfortunately, again, it's going to kind of hit the specialists the hardest. So, if you can't meet your case volume in a 90-day period, you can't meet that 20 cases, again, you won't be able to more than 3 points. So if you start early in the year and you run 180 days or 270 days, then it's a lot easier to get your case volume up and you can get those into that 3 to 10 point range. Benchmark's not going to spend much time here. There needs to be at least 20 reporters that have that minimum case volume. So again, on some of those very specific specialty measures, it may be really difficult to get that. So not all measures are going to have a benchmark, and if they aren't, you're only going to get that 3 points for measuring that measure. Bonus points here, if you have additional high priority measures, and most of you have quality initiatives, right? I mean, so those quality initiatives count something. So if you have additional high priority measures that you're measuring, you can get some bonus points for those. And if it's an additional outcome measure or experience, then it's worth 2 bonus points. Any other high priority measure is worth 1 bonus point. So in each one of these categories, where we're going to discuss what the test pace means, and this is only applicable to the year 2017. I don't know if it's going to reach out into 2018. Some indications are there's a lot of pressure to slow down the process a little bit, so it may, it may bleed into 2018 some, but I don't take that to the bank. Early indications are that there may be some slowdown in some of this. So for 2017 only, this is what we know. You meet one measure, 17, if you report on one measure, that will give you the 3 points necessary to get you to a 0 adjustment. So at minimum, pick one quality measure. It's for it, no payment adjustment in 2019. Of course, over in the other side, earning some potential incentives. Get data to CMS. You don't have to do everything in a single way. If you're reporting as an individual or if you're reporting as a group, you can measure quality and submit quality via clinical or qualified clinical data registries. You can do qualified registries directly from EHR or claims data in some cases. All cases have benchmarks for each one of these things. So with ACI and improvement activities, multiple ways to report CMS. I do want to spend a little bit of time on this, in particular in the quality area, because when you think about how you're going to report, it has a really profound effect on how you're going to get scored. So an assumption here on this slide that most everybody is not going to be submitting via the CMS web portal. So measures, plus one readmission measure if you're a larger group is equal to 70 points, or 60 points if your readmission measure doesn't apply. So you're working from 6 quality measures, trying to get as close to 60 points as you can. So it benefits you to maximize points for every one of those quality measures. And this is a very interesting segment of a table that I want to spend a couple of minutes on, because if I nothing else across tonight, I want you to go to qep.cms.gov, go down towards the bottom of the page. It was put up on December 29th. The file is called 2017 Quality Benchmarks and Scoring. And open it up because it's got all of the measure IDs, it's got submission methods in it, and then the decile breakdown for where you will fall for a particular report mechanism and your quality measure. So now what's really interesting about this is if you look at, say, the light green section there, measure ID 317, high blood pressure follow-up documented, if to get points on that scale, the aims, you have to be at 100%. EHR submitter on that measure, you only have to be above 46%. So if you are at 50% on that quality measure and via claims, you are in the 3rd decile. If you report via EHR, you are going to be in the 10th decile. So that 1-point swing is how you report that measure. So I want you to really, I want to focus on that a little bit, because it's not always that they're trying to get you to do it via EHR, because if you look just below that, at the screening for future fall risk, you're better off reporting through a registry or a qualified clinical data repository. So it's important to look at this chart as you're making decisions, okay? Now it is also, and we've talked to some folks that have said we're working with this vendor or that vendor is going to do it for us, and our position on that is that's a legitimate way to do it. If you want to take it off your plate and let somebody do it, make sure, though, that they're sort of looking at this, because it's you that's going to end up being affected. Questions on that? Okay, is look at the file, determine what's best for you, the best way to mirror your results and send them in to CMS. Advanced information, we're going to kind of get through this pretty quick because you pretty much are familiar with use, and that's really what this is. They're scoring it a little bit different, so we want to focus a little bit of time on that. But there are certain things that you have to do, and one of them is called the base measure set. You have to do at least certain things in order to get any points in the section at all. Right? Now, understanding that there are a lot of EHR vendors that are out there still qualified, certified at 2014 edition, and as opposed to the 2015 edition, there are some concessions in there. If you are reporting with a 2014 certified product, you can use for the first year, which is 2017, you can use that objective and measure set, or you can do some combination of the both, and there may be reasons why you would do the both. If a 2015 certified EHR product in your facility, you have to use advancing care information objectives or some combination of the two. Now, what does that mean? There's basically two different sets. You have to have a base score of each one, and you're going to see in the next slide. Then you earn some performance points in guess what I'll call typical CMS math fashion. You can get a maximum score of 155, but you're only going to get 100 points for it. So get 50 up front if you do it. You can get to 90 in the performance section and then some bonus scores, but none of it does you any good unless you can get the base score. So bonus points don't help you any. Here's a slide that we do want to look at a little bit. If you're on a 2015 certified product, you would use the left-hand side. And as you'll see, you have to do at least 5 measures together. And the security risk analysis, that's going to be an attestation. Yes, you did one, or no, you didn't. You have to have an e-prescribing, numerator, denominator, patient access, numerator, denominator, summaries of care, and request and accept a summary of care through the health information exchange. So there are some very focused exchange elements in there. If you're 2014 certified criteria, you can use the right-hand table. In case you only have 4 of those that you have to meet. The one that isn't, and it's a little bit different. There's 2 health information exchange ones because they broke them out in the 2015 certification criteria. They said you have to belong to a health information exchange in the 2014 certification criteria. So, again, you have to do. Right? If you don't do these, you'll get 0 points for the whole category, which means none out of the 25 possible. So, once you get those 4 measures if you're on a 2014 product, or 5 measures if you're on a 2015 certified product, then go after other performance scores, which is additional measures. Again, these are all meaningful use measures. When you get the performance rates, pretty standard breakdown to 100. They just break it down into deciles, and wherever you fall, that's how much of those percentage points you're going to get. You're in towards 100% in this category, starting with 50 to get the base, and then an additional 50, however you can scrape them together. That gets you 100% of the category. 100% of the category is only 25% of the final score. Clear as sure. So, for you, the year, test year, range you have to submit at least those base measures. If you're on 2014, you have to submit 4. If you're on 2015 edition, you have to submit the 5 base measures. You do have to submit on all of those required measures. There are some very, very specific in here. For example, if your license doesn't authorize you to prescribe, you then, of course, can't do e-prescribing. It will accept a null value, and it will give you a score for that. But the exclusions are very, very narrow and very specific. To get into the money, you have to submit for 90 days plus, preferably for a full year if possible. Improved final activity section or category that we have. We've got 10 minutes left before we go into that improvement categories. Anybody want to spend time on the meaningful use measures? So this is that new category, and this is actually where we started on session 1, introducing this new improvement activities session. We spent quite a little bit of time with it there. Actually, you have to say that you are doing some clinical practice improvement activities. You get points for those. So it's 15% of your total score in 2017. There's some automatic full point donations if you're a PCMH designated patient-centered medical home. Comparable specialty practices to PCMH, although that is then defined at all very well. Well, I'm going to say at all. What those comparable specialty practices are, or you're in an advanced payment model as a medical home model. South Dakota Health Home does not qualify as one of these. So, to be PCMH certified or one of these other comparables, you will automatically earn full credit. Quality, it's really easy this first year to earn full credit anyway. And, you know, it'll be necessary, but going forward, it certainly will become necessary. So, and one of the reasons why I can say that with some confidence is most of the practices that we work with, either the larger practices are doing many of these improvement activities, and the small practices get some additional breaks if you're under 15 providers, or you're in a HIPSA, or you're in certain designations of rural or frontier. You only have to do 2 activities, and one of those is joining TCPI, which is you do that at no cost to you. You can just do it, and we'll help you get there. So there are subcategories under activities. There's about 97, I believe, total activities that clinicians can choose from in these subcategories. You have to pick, you know, a certain number from certain subcategories. Doesn't work that way. You can pick them all from one if you want. And they're pretty liberal. There's a lot of activities in there to choose from. Again, if you go to qpp.cms.gov, and in this case the link is up there on top, you can go and explore the measures. It's probably noting this is not how you attest. You don't attest through this site. This is purely informational. But you go in, you can look at all the activities, you can look at all the measures, and when you do go into that section of the website, this is how they lay out improvements in access as a result of working with the QUIN or the QIO, right? So, and it gives you that activity weighting, which in this case is a medium, or medium activities and high weighted activities. It's like Burger King. There is no low activity. medium, and go up from there. So there are medium activities and high activities. If you're in one of these special organizations, you know, that you're small enough, you don't have 15 clinicians. If you're rural or geographic HIPSA, you know, if you're non-patient or facing, like some of the specialist practices are, anesthetists, for example, maybe you wouldn't be able to meet some of those patient-facing criteria. There's some special rules than that. Essentially, this sheet shows that most people would never have to do more than 4 activities at 40 points. For those special considerations, you only have to do 2 activities. Because in this category, you reaching for 40 points. Each medium activity is worth 10 points. Each high activity is worth 20 points. The middle box here is that alternative activity weighting column, which for those small and rural providers, where they're just basically doubling the point value. So in order to get to a total point value of 40 in this category, a small or rural place would only have to do 1 high impact activity. And I know for a fact that participating in TCPI, Practice Transformation Networks, is a high impact activity. So you would get full credit for that category just signing up with us, and that's at no cost to you. Is in a PCMH certified setting or medical home or similar specialty practice. Again, those specialty practices haven't been well defined yet to this point, what the minimum requirements are going to be, but full credit for that category if you're in one of those. So, and then final, what does test pace mean for you? Submitting 1 improvement activity, either high or medium weight, will get to that 3-point bar. So if you do one of these, and it should be noted actually that in one of these test pace things that we've talked about, so any quality measure that you report on 4 or 5 of the base measures, that's the one that's a little bit icky. You have to do 4 or 5. You have to do all the base measures to get advancing care information. Or submitting 1 improvement activity. Not one of each. It's 1 or 4 measures for meaningful. So yeah, I'd like to see you over in the participation, but we understand that some people are going to choose to do a test pace this first year. So categories, when you look at improvement activities, you can do that through attestation, and the attestation portal hasn't been brought up yet, so which gets back to Dr. Traub's question a little bit. I don't know exactly how we're going to report on some of these things, so it'll be kind of difficult for me to answer those kinds of questions. I do know there's going to be multiple avenues. The expectation is, just like with the quality section, it may make some difference, although I think improvement activities for year 2017 are just going to be attestation in the sense that are you doing it or are you not doing it? I don't think they're going to be measuring them. So with my contact information, and with that up on the screen, and certainly open it up for the final 10 minutes here, generate some questions. If we don't have any questions, we'll give you 10 minutes back, but I think there'll be some questions out there.
Thank you, Dan. This is Mark here. And, you know, the one thing that we have come through is we've done these 4 programs. It certainly is a lot of information. And so I know it's easy for some folks that have followed up after the fact, you know, basically tell us that they're a little bit overwhelmed. And so I do want to say thank you for doing this, but I also know that your team is out there. And so I want to reassure these folks that if they have questions or they think of something today, tomorrow, or next week, that they can always reach out to you. You have been very good about answering questions that people have.
That's what we're here for. And quite honestly, I don't think I mentioned it before, but CF is paying us to answer your questions. So please ask them.
Anything for Dan at this time? say to Mark again, and I do have one question, maybe to get us going here, but you alluded to that you're seeing some communication indicating that maybe slowing some of this down. And so I guess I probably have a question here that a lot of people have in the back of their mind, and that is, are you seeing any indication with the new president-elect coming in, some of this will be overturned? You know, historically, CMS has come out with different programs, and it seems like they get stalled 6 months, they get stalled a year.
Yeah.
And ID10 is one of those that comes to mind. And so I'm curious what the read is so far on this program.
Well, my read on it, and I was in Baltimore in early December, as some of your members might have been, and we're put on a brave face, but I felt like there was a little jitters under the surface. And I think the biggest jitter is not around the quality payment program, because that was pretty solid bipartisan legislation when it was passed in 2015. So I think that portion of it is pretty safe. I do think what's in danger, in particular with all of the stuff surrounding the Affordable Care Act and the possible repeal of sections of that, is CMS's Innovation Institute, CMMI, for Medicare, Medicaid Innovation. That program is where a lot of these support services are funded through. So there's some danger in how that's kind of tied back to the ACA, because it's some funding through ACA, and so there's some danger there. I suspect it again would be if cool heads prevail, it would be a slowdown, not a complete reversal, because I don't think there's anybody in D.C., Washington, Republican or Democrat, that it's sustainable the way it's going, right? So, I think might see some slowdown. I don't think we're going to see full reversal of this.
Okay. Yeah, I do have one question that came in, and I just detected here. It says a group of 5 docs share a tax fee, but only 2 who participate can work for the group, or is payment individualized to the NPI provider?
You assigned your billing rights to your tax ID. 5 providers in a practice, providers fall into the group. So it's not based necessarily on, you can't pick and choose eligible providers. If you've got providers and they've assigned their billing rights to a particular 10, it follows the 10. They're not individuals in that sense.
Okay. Any other questions for Dan at this time?
Schrader, thanks for the presentation. I have a quick question. It's not really quick, but of resources, if you would, please. What status of clinics and federally qualified rural health clinics and provider-based clinics that build a lot of services under Part A? Where do they fit all this in the future? You got any thoughts or comments on that?
Let me call somebody at the QIO, Steve.
We're talking ourselves.
I don't know the answer to that for sure. My suspicion is, of course, that just like with the private payers, if this saves people money and improves care, they figure out a way to get it done.
Yeah, that was.
That's kind of where you guys are coming from, and I think one of some of the things we've been delving into that legislation pretty hard around that area, because we've got so many cause and some things like that, and there are some real nuances in how even now they're counting people that work in rural health clinics and cause. So I mean, especially like you say, I mean, especially for method 2 billers, or the all-inclusive folks, you know, they would meet the requirements, but in fact, there are, like I said, there's some nuances in there that in some situations when they've assigned their billing rights and you're a COP that does method 2 billing, and
Very complicated, doesn't it?
yeah, it is, and I suspect that that's kind of that first initial start of that movement in that direction. But it depends on whether or not it actually improves care and saves money.
We're waiting from the GP Quinwise on the bid on those clinics under 15 providers too. So that's supposed to come, I think, sometime in February. And there may be some insight when we get that contract is where this is all going for some clinics, rural clinics.
That's right, and that's a great point, actually, Dr. Schrader. For those who aren't familiar, there is going to be some additional assistance for all clinics coming out. What we've been hearing is maybe the end of the month know something. And I know that Dr. Schrader's group put in for that. We're partnered with Telligent out of Iowa, and likely if you get the bid for South Dakota and North Dakota, we'll somehow figure out a way to work together on that, I hope. But you know, in those smaller places, you'll have even additional support. So, aware that CS is really putting some money out in to try to get this done.
This is Mark. We have two experts on the phone. One question I always like to ask, because again, this can be a bit overwhelming the first time you hear this, or even if you've heard it a second or third time. Your recommendation in terms of where should a person start off? How do you get readiness and start to develop a plan to move forward?
I'd call somebody at the QIO or here at HealthPoint to check that question very specifically. We were just talking with a group on the western part of the state, and you really have to talk to somebody about the nuances of your situation. But I know Ryan and his team at the QIO are standing by to answer questions.
Holly Aaron knows about that also. She's very updated on that.
That?
Holly is
absolutely.
Yep.
Yep. There's resources out there, and use them. Don't try to go it alone. I mean, it's just, as Schrader said, it's so complicated, and you are already so busy doing the work you do. There's no trying to figure it out alone.
Here's one question for you. Just popped up. It says, if I dump EHR and see 30% more patients I had, even with the MIPS hit of 9%. But I think at one time, Dan, you had mentioned it could swing up to 18%. Is that correct?
Yeah, that's true. It's a negative 9% adjustment on Medicare Part B payments. In ways, it's difficult for me to argue with that logic. I think there are, and having done this for the past 10 plus years, the unfortunate thing about EHRs, and I recognize some of the frustration out there. I recognize people doing rip and replaces. It's just such an infancy that in the next 10 years, we won't be having this conversation at all. I realize it's painful now, but in a better place. I give you that advice.
Okay, questions for Dan, or since we also have Dr. Schrader on the phone with the QIO at this time? Okay, hearing none. Dan, one more time, would you mind going over your contact information so if anybody does want to follow up with you with additional questions?
Absolutely. Easiest way to get a hold of us, Call number 256-5555. Anybody get a hold of here will point you in the right direction. You send me an email at dan.fredrich, spelled Fridge, and at dsu.edu.
I certainly want to thank Dan for helping us with this series on MACRA. Please note that this presentation and all other presentations have been recorded, and we will put those out on the SDSMA website, so you're free to access those at any time. Those of you that are interested in category 1 CME credits, they are available through Avera Health, and you basically X out of the program tonight. It should take you to a web page so you can register for those credits. If you have problems, please let us know. Last thing I want to mention is that we're going to start working on another series, and we're going to basically build off this MACRA stuff, and we're going to be working on this series with the QO. So I thank Dr. Schrader for calling in. The goal of that series is to look at population health management and care quality improvement from a practical, hands-on approach. Information regarding this next series is going to be forthcoming. So with that, I certainly want to thank Dan once again. I want to thank all of you for participating. And I will close by saying that if you have any questions, please understand there's resources out there. Don't be afraid to reach out and use them, because that's what we're all here for, is to try to help you get through this. If there's no other questions, wish everybody a good night.
Thank you.
Bye.